Good morning. James, would you like to stand, please? Well, I was very honoured and privileged to receive the award on Tuesday on behalf of the Trust. A lot of the work that you are going to see in this presentation is a result of this gentleman's individual efforts as well as his team. James is my procurement manager, and in my more lucid moments tends to take my better ideas and turn them into reality. If I could also make a plea, I've been very motivated by some of the things that I've seen during the last 2 days, but there is a plea that I would make on behalf of users to both regulators and to manufacturers. Could you get on with it, please? And as Ulrika said, this will probably be a very strange presentation. It will not be the usual type of presentation that you probably get from a normal NHS person. I am not a touchy-feely healthcare individual. My past has been in FMCG and in venture capital. And unfortunately, when things get in between me and providing good patient care, or actually improving the efficiency of my office, my hospital, to actually give good patient care, that aspect of my personality tends to come out. Because the important fact is we're here to treat patients, and at some time in the future that patient could be my mother, my wife, or my daughter. So I'm afraid I don't take prisoners. This is not my office, by the way. This is the front door of my hospital. So I'd just like to tell you why we are so passionate at Derby and actually of the work that we do.
The Royal Derby, one of Britain's newest and largest hospitals, treating 1 million patients a year.
In hospital!
Every day here, lives begin and lives are saved.
The stakes are high. The decisions we make the difference whether a patient lives or dies.
Right, who am I going into battle with now?
Behind every life-changing moment
Calm down. Oi!
Not going to make toast.
is an extraordinary team of over 8,000 staff,
Living the dream, you and me here, aren't we, Stample?
each one dependent on the next.
We are like a little work family.
Take one member of that family and it doesn't function.
3, 2, 1, go!
Continue this search for a missing patient. You look after us.
So much.
Pleasure.
From the surgeons to the sweepers,
You behave yourself, that's all I ask.
You did so well.
these are their stories.
I just need to get this right.
It's quite intense, but it's what we do.
Okay. So, when I joined Royal Derby 2.5, 3 years ago, like many other NHS trusts, as Jackie very aptly pointed out on Tuesday, the stock control system is a shambles, to put it mildly. And certainly coming from FMCG, it rendered me speechless at times. But you can imagine how motivated my clinicians would have been if I'd have gone to them and said, my God, have I got a super stock control system for you? So we had to sell the idea. And naturally enough, coming from FMCG, we have started our thought process on the basis of point of use. So therefore, these rather large businesses have built their success on their ability to tell what their customer is buying. Why can we not do that in healthcare? So why not the patient? It's very sensitive. So, as you will have seen, and it's not unique, this is all based on the patient wristband. It is also based on the unique code that we put on patient records, because we believe that the application of GS1 can actually track and trace and actually record all the items that you've previously seen in that video. We do not see it just as a supply chain solution. And hopefully you will see some of the ways we're developing the use of GS1 in our organisation. So, how do we get clinical engagement? Because to be honest, you will save money in your supply chain, but actually the real prize is getting changes in clinician behaviour. So we sell the idea to our clinical people by patient safety, the identification of out-of-date stock, traceability of instrument and implants, but in more particular case of Derby, a coding improvement, and therefore a rather sensible conversation that you can either use this system or tell me which people you'd like to lose. And then actually then automatic update of external records and actually automatic replenishment. Because the important fact is in the NHS, we don't get paid for administration. We get paid for actually treating patients, and that's what we need to do. Okay, so our system that we looked for and actually decided on 2 years this month was a solution that was used in Australia called HTRAC. We scan high-value items. The hand unit is actually fully mobile. It is barcode agnostic as well as location agnostic. We put low-value items into packs, which may be one of the learning lessons for our friends from Bernhof. And we scan surgical trays for traceability and cost, and we also scan scopes for traceability and cost, and also for maintenance. We now have total process automation as a result. Our PO and invoice transmission is all electronic. It reduces administration time in delivery matching. It's totally people conformant, and as you can see, it is usage-driven replenishment. We do not buy what we don't use. We only buy what we use. And this is our system. So from point of care, where the original information is actually tracked to patient, it goes through our stock solution, which is managed by our e-catalogue. Nothing is bought if it's not on my catalogue or at the price that we have agreed with the supplier. It is totally contract controlled. It automatically feeds into my trust PO and accounts payable system, and then sends eConnect requests to the supplier, and then we get electronic information back the other way. And what this system then does is feed into my patient level individual costing system, and in particular to my coding. And this is why I'm saying, please do not just look at GS1 from a supply chain point of view. It could be all-encompassing, and we believe it can actually help a management information system that will improve clinical care. We're currently operational in 9 general theatres, 3 general day case theatres, and as you can see, a wide area of other specialties. We intend to roll out to 16 further theatres, as we have 35 throughout the hospital during the next 6 months. We started, as you can see, actually initially planning this in November 2013, and we rolled out to general theatres in April 2014. Now, there was a reason for that. My general theatres are my multi-speciality situation, and also I had a very compliant theatre general manager, because without that compliance, it's very difficult to get any system sorted. Because if your clinical people are not committed to this sort of thing, it will die a death, and it will die a death very rapidly. We left it deliberately to run for about 9 months before we started our next implementation. But as you can see from the lessons that we learnt and the stability that that period gave us, we've been able to accelerate the rollout of the system across the hospital. And we intend every area of the hospital to be using the system by the end of 2016, and that includes ward scanning, bedside scanning, outpatient clinics, and outpatient procedures. So the point of entry for a patient into the hospital will apply GS1 standards to all the areas of that patient journey. And that will allow us to record electronically what is happening to that patient and who is applying what and when to that particular individual. So currently in theatre, our patient is scanned and checked on arrival at the anaesthetic room. That means we don't have to ask him 27 times whether he's still Mr. Smith. Our staff are scanned and tracked. Each of our staff have an individual GS1 barcode, so if you're not in theatre, you don't get scanned. So we can tell when the consultant has actually asked the registrar to start his list. We can track scopes and instrumentation, our loan sets. We capture the lot number in case we get product recalls. We prevent expiry wastage, and actually the system will actually flag at the point of application of the product to the patient whether it is out of date, and the clinical staff can then make a decision to either utilise that stock or actually replace it, and then the system will reorder double the quantity that is actually used in the theatre. So further value from that gives me detailed and accurate data for PLIX. It gives me automated replenishment of stock. It's reduced my stock taking from a day to half a day. It's reduced my stock holding, and it actually drives down my delivery charges. Nothing dramatically different, I think, from any of the experiences of my colleagues who have presented to you during the last 2 days. Just to say that overall, my operating consumables in general theatres have gone down on an annual basis by 7%, and the same figure for cardio cath labs is a reduction of 12%. So, why do we need traceability? You will all, hopefully, if you read the English papers, be aware of the situation with horse meat. And it was actually reported in The Sun that Tesco's were able to remove all the products from their shelves within 5 minutes. So it must be true. But then again, and I apologise to our supplier base, that would never happen with such a high ethical supplier base to the medical industry, would it? If we'd have had our system at the time of this little problem, we would have been able to tell a lot of ladies very quickly whether they had a problem or not, and actually start the treatment a lot quicker than was needed. So, this is where we've started to leverage actually the use of GS1. We've actually taken our own license and started producing our own GS1 barcodes. You will see on the right-hand side, this is our standard barcode for our gown units that go into theatres, and here is actually our general anaesthetic kit. And here's one I made up before. So my stock guys have worked with my anaesthetists, and that is the general anaesthetic kit minus the needles, because they wouldn't let me on the plane with them, that we actually use in all our general theatres. It gives you total traceability, but also allocates the cost of each of those items automatically to the cost of that patient. We've even, as you can see, this is Mr. Leader's Lap Coley standard pack, and again we've issued standard GS1 barcodes or specific GS1 barcodes to individual surgeons who are fairly standard in the approach to the usage of consumables for a particular procedure. What we have done though is actually taken it one step further, and we now scan in theatre the procedure that the surgeon actually says he's undertaking. and this has a dramatic improvement on our coding income and the recording of the procedures that actually occur in theatre. One of the areas that we identified where we were short is actually our income, and that was identified as a problem in our coding area. Sorry, our noting area, because it was actually not our coders that were the problem, it's the fact that our doctors were not actually recording the level of information that they required. So this now is what feeds through from my data warehouse into my coding system for individual patients. So my coders are actually able to see what the doctor is doing at the time he's actually undertaking the procedure. We've then again taken this one step further, and I'm so glad they didn't call this Big Kev. Big Steve now actually appears on the inside of our anaesthetic rooms and also on our outpatient clinics, and we're able to scan the comorbidities of an individual patient and automatically put that into our patient record. And this has been the impact. This was the point of the introduction of H-Track into general theatres. And the reason why I know that impact is down to the use of our system is the fact that all the specialties in general theatres caused that uplift, and trauma and orthopaedics, where the system wasn't in, didn't move. That equates on an annual basis to just over £2.5 million. But the other important fact that we've had is the improved relationship with our clinicians. This is a maxillofacial tray and is usually filled with 150 screws. That's these. That goes into theatre when actually my maxillofacial surgeon is implanting either a plate or reconstructing a jaw. And he will use on average on an individual operation about 6 to 8 of these. The problem is we were buying unsterilised items and putting them into this tray, sending them through our CSSD and actually paying £28 for the privilege. We've now, with the fact that my clinicians have understood that we actually have human beings in procurement, been able to change that to actually an individual item that we buy for only 70p more than the unsterilised item. So I'm paying approximately £4 to £5 more, but saving £28 every time I send that tray round for cleaning, because I actually only use what I need to. And my clinicians will actually tell you this is a lot safer because they can actually select their sizes a lot easier, but also it has total traceability to the patient because I scan it against the patient barcode. So, the major factor at the end of the road, though, is actually the clinical information that I'm now being able to get out of the system. And one gentleman in one of the workshops said, actually, our clinicians worried about this. Well, clinicians are actually very competitive. And therefore, the fact that when you start to compare them, they all don't want to be at the bottom of the list makes for some very interesting discussions. This is what originally used to come out of my system, which is an individual cost sheet. But it's slightly different than normal because you will see it actually refers to the procedure that's being undertaken. So I'm actually, on a one-for-one basis, now able to identify what I'm spending to undertake a particular procedure by a particular surgeon. I'm also able to identify who's actually in theatre and what is the job that they're doing. So I know if it's a training session or actually whether the consultant is in that operating room. And there are the costs with the individual items for that particular patient and that particular procedure. That has now evolved from my data warehouse into the following reporting, and I'm sorry for the eye test. But what we're now able to do by clinician is actually drilled down to individual operating procedure and how much it's actually costing and the length of time it's taking and the number of people that are actually in theatre. So this makes for a very interesting discussion between the top 3 surgeons. As you can see, we have different consumables, and that's probably because Mr. Chu has only undertaken 1 procedure. But it also has a very interesting discussion with Mr. Corsack as to actually whether he's undertaking the right procedure. And so what we can do is look at Keith, who is my clinical director, who actually uses on average 90 products, but has 8 people in theatre, but takes only 212 minutes on average for that procedure, against his counterpart, Mr. Dickinson, who actually needs only 7 people in theatre, but takes slightly longer. So the clinical decision is, actually, is it better for me to pay for HCA in theatre to actually get that increased throughput between an individual surgeon so that I end up with an additional patient on that theatre list rather than trying to save a few pounds on consumables. And as a byproduct, can you knock it on? Doesn't. Can you tab it on? And out of the back, I then get my hidden benefit, which is my procurement information, and then it's a discussion with the supplier. So out of the same information, I'm actually driving 2 discussions, one about clinical practice and clinical variation, and one about actually the products that I'm using and the price that I'm paying. So I actually get my procurement information for free. And as a venture capitalist, I love that. Thank you. Any questions?
Any question on that side, please?
Thank you for a very impressive presentation. Now it's on, obviously. Thank you for a very impressive presentation. I couldn't agree more with you. Just asking, what is the degree of integration of the IT functions that you have displayed there with the IT functions of patient record and other sort of IT subsystems? To what degree have you been able to integrate so that the information that you gather propagates to other subsystems, clinical subsystems, without people having to do work twice?
We're currently in the process of building interfaces to my Lorenzo system, which is my electronic patient record. All that information currently is held in a data warehouse storage unit, and therefore it can populate any of the individual systems that we use within the hospital. And it's not actually determined by having to have that interface before we implement the system. So I think one of the things, and I recognise the points that you were raising yesterday in the workshop, we've just got on and done it, and we'll build the interfaces later, because this system is actually paying more than paying for itself and actually improving patient safety now. I'm not waiting for my IT people to catch up. Is that okay?
Yes, I see no further questions. Thank you so much. Oh, wait, no, sorry. Too early.
Sorry, Siobhan Duggan, GS1 Ireland. Thank you, Kevin, that was excellent. Could you comment on your ability to recall and the recall process in the hospital, please?
Yes, we're able, at the touch of a button, if we get notification about an individual product, to actually identify which patients have been implanted with either that item or have been actually touched by any consumable, so that we have a total view in terms of being able to identify the patients affected.
Sorry, Kevin, just one quick question. You have your clinical team scanning GS1 barcodes, which probably have the ICD-10 code in them, is that correct, when they're doing the procedure?
I knew I'd invited James for a reason.
Is he nodding?
To be honest, not all suppliers provide GS1 barcode, which I think we're all kind of aware of at the moment. So where that actually doesn't happen. Thank you. What I was just saying is, yes, we scan at point of use. The issue that's wriggled its head a number of times is we know that all suppliers don't always provide a GS1 barcode. They do mainly provide a barcode though, and I think what Kevin refers to, what we're doing at that point is we're just making sure we're capturing that data, so we're scanning the barcode and gathering that data. I think something that Jay referred to earlier on, there's an element where we now need to assess that data capture to make sure it's exactly what we think it is or it ought to be as well. But yeah, we literally scan the barcode, 2 stages. I think what Holland did before is I think they scan over a certain value. What we do is we do the same, but then what Kevin refers to is we have then procedure packs which we work with. So we then have a barcode. I think Kevin mentioned that full traceability for those procedure packs. Actually, that barcode is just capturing those products to say, for patient level costing points of view, because those items won't actually really have the recalls because it's everyday low value items. Does that answer your question?
I was actually referring to the ICD-10 code, procedure code that was performed.
Okay. So the actual code, yeah.
Yeah.
We do.
You scan that.
Yeah, OPCS.
But that's not an official,
No, but
our OPCS code we've actually made up.
Right.
We're trying to get HISIC to adopt nationally, because I find it incredible that actually they publish OPCS codes and actually comorbidity codes and don't actually apply a GS1 barcode, because then it would be the same nationally. And surprise, surprise, we would then be able to tell exactly what an individual procedure was costing us throughout the country, rather than the Machiavellian practice of RCI calculations. So we'd be able to have more informed discussions about whether we were actually being paid correctly for an individual procedure.
And that is quite interesting because there's obviously over 10,000 of these codes. So in general theatres, when you've got multiple specialities, the consultants are the people to know, because the majority in the UK do a lot of private business as well. So them getting that code correct is in their head, because of course in private business that's how they get their income. So them capturing it there helps our coders enormously.
Yeah. So don't let your clinician tell you he doesn't know the OPCS code if he's got a private practice, because that's the only way he gets paid.